My name is Meral Beksac. I'm located in Ankara University, Department of Hematology and Stem Cell Transplant Unit. I've been working in the EBMT plasma cell disorders subcommittee, and we have a paper, a publication, which is in press at the Journal of Bone Marrow Transplantation, which highlights the importance of prediction of early relapse post-autologous stem cell transplant. In this effort, we had managed to analyze among more than 14,000 of first transplant myeloma patients newly diagnosed, and within a subset of more than 7,000 patients, we used it for training purposes to build up a score that predicts the early relapse within the first 12 months post-transplant. And we tested our score among more than 5,000 patients who received MEL 200, and also in addition 1,500 patients who received MEL 140. As we all know, anything related to the outcome in myeloma is based on patient-related and disease-related and also treatment-related factors. And by random and without any supervision, the statistician, which is Simona Jacobelli, she found out that ISS, patient status prior to transplant, and also response status prior to transplant. So these three belong to the three categories that I briefly mentioned earlier. They play the major role in terms of building up the score. And finally, well, with the use of this score, we were able to find out that it is possible to have 5 categories of patients who have a risk of relapse, with high risk of relapse, around 50% within the first 12 months, and very low risk of relapse, which is around and less than 10%, ranging around 5%. So these low 0, 1, 2, 3, 4, 5 4 categories were validated in the validation cohort and also in the MEL 140 cohort. Earlier, there have been 2 more attempts to build up early relapse scores by GMEMA and CIBMT ER groups, and with an aim to compare these different 3 scores within an external data set. During the last EBMT Congress, we were able to analyze our data from Ankara University among 410 patients who received MEL 200 and who received triple induction regimens mostly, and who were unmaintained in the majority because of regulations. And in comparison, I have a slide that here shows the difference between the outcome of PFS 12. On the left side is the EBMT score, which shows a very low risk of relapse, less than 5%, versus 50% in the score 4 category. Whereas with the GMEMA score, it also discriminates the risk, but the low risk is 56% versus the 47% with the EBMT score. However, with the CIBMTR score, the discriminative capacity, although it is statistically significant, the difference is ranging between 86 versus 82%. And furthermore, to add on top, as also is present in the EBMT publication, and this score is not only able to predict early relapse, but also overall survival at 3 years. And here we are also able to compare the differences between overall survival, which is significant for only the Jumema and EBMT scores within our data set, but not with the CIBMTR score. So finally, I can conclude that with the validation in an external cohort, EBMT score, which is a very easy score based on ISS and performance plus response status prior to stem cell transplant, has a high predictive value in terms of discriminating patients with a very low versus very high risk of relapse. So for future, we are hoping to validate in other external cohorts, and we in the EBMT presentation, we showed our attempts to improve the score, the EBMT score, replacing ISS with RISS or with MRD assessment prior to transplant. But it eventually came up that it is not adding much value within our 400 patient cohort, but maybe in future among bigger cohorts that this can be possible. But it is also important to note that FISH by cytogenetics has been shown by the IFM group that only 17p deletion has a uniform value in terms of poor prediction, in terms of prediction of poor response. But the others are not unique, and there are different subtypes of, for instance, 414 or other 1416 translocations. So FISH is not an optimal tool, but MRD assessment can be of additional value. And another weakness of our study is the value of the score to validate among patients who are maintained. And during the EBMT presentation, we show that high-risk patients do not benefit from the maintenance. And so we are able to recognize with the EBMT score those who are going to relapse despite being maintained. So I think we are in an era which is moving fast, and it is also possible to develop scores to predict early relapse. Thank you.